Hello, I'm Dr. Kathleen Buckley, and I'll be speaking to you today about how to develop goals for a quality improvement project. It is expected that following this presentation, you'll be able to compose SMART goals, short, mid, and long-term goals, structure, process, and outcome goals, and distinguish the difference between goals and benchmarks. Have you ever been on a journey and not had a good map? When looking at a map, there may be many roads that lead from spot A to B, and you're going to need a good map to know what is the best route and which direction to take. Otherwise, you may end up wasting a lot of time just driving around. The process is similar to what happens when you do not set goals for a project. You will feel like you're driving on a road where you're unsure of your destination. In contrast, when you set goals, it gives you a straight path and a clear direction as to where you need to go and what you want to achieve. Writing your goals as SMART goals that are specific, measurable, achievable, relevant, and time-specific will add clarity for everyone. So let's go through each of these requirements one by one. The S in SMART is for specific. The goal should specify the who, where, and what. And here's some questions to ask when you write a goal. Who will implement or evaluate the practice changes? That who usually refers to staff members or providers. But there's another who to consider, and that is who will be impacted by these changes. And that who usually refers to the patients or the populations who will be affected by the practice changes. And then where do practices need to change, in what kind of setting? And finally, what are the changes you and your implementation team need to make? So here's two examples of the basic elements to include in a goal for it to be specific. The first example begins with who will make the practice change. So in this case, it's RNs. They're going to make the changes at Fabulous Clinic. That's where. And they will administer flu vaccines. That's what. To the patients who meet the eligibility criteria. That's who will be impacted by the changes. The second example begins with who will be impacted by the changes. So in this case, the post-surgical patients, that's who's going to be impacted. On the medical surgical unit, that's where, will achieve a level 4 status of ambulation as defined by the bedside mobility assessment tool. That's what. And then as evaluated by staff RNs. That's who's going to make the changes. Either of these formats is acceptable because they include the who, the where, and the what. The M in SMART goal stands for measurable. And when you write the goal, you must include the criteria you're going to use to measure or track achievement of the goal. QI projects are always evidence-based, and that evidence must be based upon data or measures that you collect. Otherwise, how would you really know if the goals were met? And so by measures, we're referring to quantitative measures of success usually. For example, if you wanted nurses to screen all the patients admitted to a medical surgical unit for the risk of falls, you would include in the goal the percentage of patients who were screened on admission. What percentage should that be? In most cases, it should be 100%. And there are several reasons for this. First, you want to strive for the best outcomes for all the patients and not leave anyone out. There's no reason to only screen 80 or 90% or some other arbitrary number. And it's impossible to know how many of the patients might be affected by the practice. It may be possible to impact all of the patients, and you don't want to miss anyone who could possibly benefit from the practice changes. It's also impossible to know how long it will take to reach the 100% mark, and you don't want to simply guess. If you set the goal too low, then the staff may stop trying when they reach the goal, rather than continuing to strive to ensure all the patients received evidence-based care. There are some other reasons why the measure should be at 100%, and they relate to health equity. Often, the patients who are in the last 10 to 20% to receive the intervention are the most vulnerable patients who need evidence-based care the most. It's not acceptable to be content with the subset of patients receiving non-evidence-based care. The 100% expectation should be set early on in the project. Let the staff know that the work is not done until all the patients get the care that will lead to the best outcomes. All QI projects must work to eliminate disparities, not perpetuate them. For example, if you were to restrict the practice change to only English-speaking patients because it was easier to implement, those patients who may be the most vulnerable would not get evidence-based care. Let's look at our previous examples of goals and add that measure. You could write it: RNs at Fabulous Clinic will administer flu vaccines to 100% of the patients who meet the eligibility criteria. Or you could write 100% of the post-surgical patients on the medical surgical unit will achieve the level 4 status of ambulation as defined by the bedside mobility assessment tool as evaluated by staff RNs. Either way, again, is acceptable. The A in SMART goals stands for achievable. When you write your goals, consider the following questions. Is the goal something people have achieved or could achieve? Do you have the resources, the staff, the equipment, etc., needed to achieve it? Is it achievable within the designated time frame? Let's look at that first question. Is this goal something people have achieved in other settings or could be achieved in the setting of interest? Is it theoretically possible if all the stars are aligned? If you're unsure, search the published literature to determine if it has been achieved in other settings. What can you learn from others who've worked to implement a similar QI project? As for the second question, to determine if a goal is achievable, you have to consider the available resources to achieve it. Are there enough staff available? Do they have the expertise they need? Do they have the equipment and/or the supplies? Does this practice change require a change in the electronic health record? And will information technology support that change? Do you have leadership buy-in? Do you have the support of your clinical site representative and sponsor? Each setting is unique. For example, you may want to implement the use of manometers to measure endotracheal cuff pressure, but the site refuses to purchase the manometers. So even though the practice change is evidence-based, you don't have the resources to implement the practice change. The third question asks you to consider if it is achievable within the designated time frame. Remember, you only have 14 to 15 weeks to implement any practice changes, so don't bite off more than you can chew. The R in SMART goals stands for relevant. Take care to not expand the project beyond what is relevant. First, ask, what is the evidence base that supports this practice change? What are the national recommendations for making this change? How does this goal relate to individual and organizational values? Did you or they identify the problem? Is this the right time for the project, or is it an immediate priority or safety issue that must be addressed? If the site has come to you with an emergency practice change that must be implemented in the next couple of months, it's not relevant to a DMP-QI project that has to fit within the timeline of the courses. Finally, what is within or outside the scope or boundaries of this project? What things are you not going to pay attention to? For example, if you're going to implement a project to increase the use of the flu vaccines, make sure that the staff has the training and enough vaccine. However, it's beyond the scope as to how people are going to be scheduled to get it. You're only going to focus on the people who regularly attend the clinic. And then the T in SMART goals stands for time. When will the goal be achieved, and what are the target dates? Again, we take our previous examples and add the time for it to be achieved in terms of months, day, and year that you plan to reach this goal. Okay, Let's take a minute to see how well you followed the presentation up to this point. I want you to pause the recording and then read this goal carefully to evaluate what it's missing. Okay, let's break it down. The goal is time specific for reaching the goal. It also has a measure of the percent of patients who will be impacted by the change. It has the setting and the outcome expected. But what is missing is who is responsible for making the change or evaluating this blood return. Is it someone in the radiology department or someone on the transferring unit? And who is that person? We clarify this by adding that information. We discuss goals as being time specific. We're going to drill down on time a bit more in this next section. Project directors usually find it useful to separate goals and planning into phases based on time. This allows them to track immediate improvement over time while also evaluating progress toward future goals and targets. Let's discuss the differences in short, mid, and long-term goals. First, always start with the long-term goal or the end in mind when you're writing goals. What is your North Star? Why is this change needed? What patient outcome is being targeted for change? A long-term goal is a patient or a population health outcome goal that evidence-based practice changes are meant to affect from 1 to 5 years from the start of implementation. Here's an example of a long-term goal for a hospital that's trying to increase long-term breastfeeding rates of the mothers who deliver babies there. By September the 1st, 2023, 100% of the mothers who are breastfeeding their infants at discharge from the mother-baby unit will sustain breastfeeding for 6 months or longer as evaluated by the hospital quality improvement staff. Now, the next more recent phase of goals would be a midterm goal. This is defined as a structure, a process, or an outcome goal that you hope to achieve by 6 months to 1 year from the start of implementation. If we think about the long-term goal of increasing mother-baby breastfeeding up to 6 months, what kind of process might you put in place to achieve that? Well, we know based on evidence that the use of skin-to-skin contact between mothers and their infants following birth deliveries increases the rate of long-term breastfeeding. So keeping that in mind, the midterm goal could be by July 1st, 2022, 100% of stable mothers who give birth either vaginally or surgically to healthy newborns in the labor and delivery unit will have their newborn placed skin to skin within 5 minutes of birth by a labor and delivery nurse. This happens to be a process goal and describes the expected behavior of the staff. And then finally, we come to short-term goal. This again can be a structure, a process, or an outcome goal that will be achievable in 3 to 6 months. And that time frame is consistent with the time frame that most DNP students have to implement their quality improvement project. Here's an example that follows the previous ones, but could be achieved by the end of the implementation period for the QI project. By December 15th, 2021, 100% of stable mothers who give birth vaginally to healthy newborns in the labor and delivery unit will have their newborn placed skin to skin within 5 minutes of birth by a labor and delivery nurse. The difference here is that the practice change will initially focus on infants born vaginally. Note that the midterm goal was for infants delivered both vaginally and surgically, and this one is only for vaginally delivered infants. We need to be clear that the definitions provided by this presentation for short, mid, and long-term goals are not necessarily consistent with those used by other organizations, but are how we define them at the University of Maryland School of Nursing and specifically for DNP students' QI projects. Hopefully, you will now see there are different ways of describing goals. And thus far, we've discussed the elements of a goal based on the acronym SMART goals. We also discussed having different goals based on the phases of the practice changes being implemented. And finally, we want to look at the types of goals or structure, process, and outcome goals. In the next section, I will define these terms and provide examples. Structures are physical and organizational characteristics where healthcare occurs. So they first include physical characteristics of a site, such as space or equipment availability, or information recorded in the electronic health record. Organizational characteristics include staff-patient ratios or the amount of education the staff has received on how to care for patients. Staff development and changes in the EHR are common changes in structures. Processes are the specific behaviors of health professionals or how health professionals take care of patients. And then outcomes are the end result of the changes in structures and processes and are the effects of the healthcare on the status of patients and populations. All DMPQI projects will need to have at least one structure, one process, and one outcome goal. Depending upon the practice change being implemented, the outcome goal may be a midterm or long-term goal. Structures, let's look at the definitions of each and an example. Remember, a structure goal includes physical and organizational characteristics where healthcare occurs. An example would be by September 30th, 2020, the implementation team will educate 100% of the staff RNs at Fabulous Clinic on the eligibility criteria for patients receiving the flu vaccine. Since all QI projects require some element of staff education, all DMP QI projects should have at least one structure goal related to staff education. Okay, here is process goals or the specific behavior that's expected of the health professionals in delivering care to patients. An example would be by December 15th, 2021, 100% of the patients at Fabulous Clinic who meet the eligibility criteria will receive the flu vaccine from a staff RN. And finally, we have outcome goals, which are the end result of changes in structures and processes and are the effects of the healthcare on the status of patients and populations. An example is by July 1st, 2022, 100% of the patients cared for at Fabulous Clinic will have no preventable flu-related emergency visits or hospitalizations as tracked by the administrative support staff. So let's pause a moment and see if you can identify the differences among the structure, process, and outcome goals. So pause the recording and read each of the goals, and then try to match the goal with each type. And when you're ready, restart the recording to see how well you did. Here are the correct answers. How did you do? Putting it all together, here are some templates with the basic information you must include writing SMART goals. The first two are useful for writing goals for structure or process changes. You should insert the specific information related to your project within the red set of parentheses. So you would delete the word date and actually add the date and so on. Whereas the last one here is the format to use for goals that are focused on patient outcomes. However, You may have to also include some other information in your goal, including eligibility criteria for the patients who will be impacted by the changes, a time when you expect the change to occur, for example, let's say 48 hours after admission, 48 hours of admission, and finally, the frequency of tracking the assessment of outcomes. Before we end, let's clarify the difference between goals and benchmarks. If you consider the broader use of the term benchmarks, it's often used to compare how one organization compares to other organizations, whereas the term goals usually refers to what a leader or a group within an organization wants to attain. I've also listed some sources of national benchmarks that you may want to look at, especially when setting outcome goals for your project. The term benchmarks can also be used in a more narrow sense when using it or applying it to QI projects. In this case, they refer to interim benchmarks that you may set during implementation of a project to help track progress towards your short-term, mid-term, or long-term goals. Here's an example of a benchmark for the process goal of having 100% of the eligible patients in a clinic receive the flu vaccine. It might be that 50% of the nurses at Fabulous Clinic will be compliant with completing the patient questionnaire to determine if a patient is eligible for a flu shot by the end of a 1-month period. This is different than a process goal. It's not set at 100%, and it's for a shorter period of time. However, it can be useful because you can use it as a check-in at 1 month and see if 75% of the nurses are completing the questionnaire, you know that the nurses are attempting to reach the goal. On the other hand, if the compliance is only 25%, you probably need increased education or motivation to attain the goal. So hopefully by now, you are able to write SMART goals that are specific, measurable, attainable, relevant, and time-specific. You should also be able to develop at least one short-term structure and process goals for your DMP project. And you should be able to write an outcome goal. It may be short-term, but it also could be mid-term or long-term. However, your long-term goal should be a patient or population-based outcome goal. Finally, you should be able to identify the differences between goals and benchmarks and when to use a benchmark. So that concludes this presentation, and I want to thank you for listening.